Hi, it's Dr. Emily Cooper. Are you a healthcare professional who wants to expand your clinical expertise and your approach to treating obesity? Beginning November 7th, I'm offering a 3-part, 20-credit live virtual course through the Diabesity Institute. This course will focus on science-based insights into diagnosing and treating metabolic disorders. I've treated thousands of patients over the past 25 years. Our clinics recorded their outcomes in a comprehensive database, and I've learned a lot that I'd love to share with you. If you're looking for clarity, a greater diagnostic understanding, and effective treatment strategies, for more information and for the official credit statement, visit fatsciencepodcast.com and click on the provider course link at the top of the homepage. All right, now to the show.
It really comes down to obesity is a disease and not a lifestyle choice, and there's something you can do about it. And that, the added message is at any age, in anybody, and we do need more pediatric weight management programs in this country. But to all the haters out there who have ever questioned me and what I do, I always say just spend one day in my clinic and talk to these children yourself.
And you'll know.
And you'll know. And you will never criticize me or what I do again, because these kids are desperate for help and so appreciative when someone will actually just listen to them and try to treat their disease as opposed to judge them for their weight or health or whatever.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. And we have a very special guest on the show this week, Dr. Evan Nadler. Dr. Nadler, it's great to have you on the show.
Thanks, guys. Thanks for having me. It's going to be super fun.
All right. I'm going to read a kind of long intro, but it's long because you've done a lot of really amazing stuff, Dr. Nadler. So bear with us.
That's what happens when you write your own intro. You make all sorts of claims that no one can fact check, and you just
I love it.
No one goes on the internet and says, wait a second, he didn't do that.
So here it goes. Dr. Evan Nadler is an internationally recognized pediatric surgeon and a leading expert in childhood and adolescent obesity. He served as co-director of the Children's National Obesity Programs and director of the Child and Adolescent Weight Loss Surgery Program at Children's National Hospital from 2009 to 2023. He was also a tenured professor of surgery and pediatrics at the George Washington University School of Medicine and Health Sciences. Before moving to Washington, D.C., he was the director of minimally invasive pediatric surgery at the New York University School of Medicine, where he participated in U.S. Food and Drug Administration-approved studies using laparoscopic adjustable gastric banding in adolescents with obesity. His current pursuits include pediatric obesity treatment program development. He's authoring a book on obesity and educating the public about obesity via his YouTube channel, website, and media appearances. Dr. Nadler has authored multiple publications and textbook chapters on the topic of pediatric bariatric surgery and was one of the founding members of the Childhood Obesity Committee of the American Pediatric Surgery Association. That was a mouthful, but it speaks to your commitment, Dr. Nadler, for this topic. I want to know, how did you get passion in the first place for treating childhood obesity?
Yeah, and first of all, thanks everybody for having me and the opportunity to help spread the good word. The sort of epiphany moment for me was somewhere in the 2000 range. Now that I'm old, I can't quite remember the dates as clearly as I used to remember them. But it was during my training, and I was at a national meeting, presenting some unrelated data. And I was it was in Disney, and it was May, probably Memorial Day. And I was sitting at the pool with my wife, and I was looking around the pool, and I was just sort of taken aback by the scene. Everybody there, kids and adults alike, were struggling with their weight. And there was a 12-year-old boy or so, who I don't want to stigmatize, but he was struggling with his weight, and he had a 2-liter bottle of Coke and a big greasy hamburger that was in his hand with the sort of grease dripping down it, and a 1-pound bag of Lay's potato chips at his poolside. And I just turned to my wife and I said, someone has got to do something about obesity in this country, especially in these kids. And so that was sort of what started it all. And from there, it's just been basically my focus for 20 years plus now.
Wow. That's a really interesting origin story. And Dr. Cooper, I'd love for you to just engage doctor to doctor, because you've been, Dr. Cooper, treating kids with obesity for a long time, but I just want to let you two engage in a way that makes sense at this point. So go for it.
Yeah. I mean, I just think my practice is also focused quite a bit on pediatric obesity. That's something that I've been involved in probably about 2 decades now. And I'm sure, like you, we have seen a lot of changes in the field because, starting out 2 decades ago and seeing how things have evolved, not just in the medical realm, but in the surgical realm. So there's been so many advances and so much, widening of our understanding of obesity. So that's where, in my practice, I see a lot of people after they've tried everything under the sun. So a lot of that image that you have of that child that you saw isn't, the typical patient that I get now in my practice, because people are health aware and families are doing all they can, to try to solve these problems. And that's what kind of sheds the light that this is not really but as I love Andrea saying, this is not a potato chip problem. This is a medical problem.
Right. And even though that was sort of my origin story, as Mark
Your
had
origin,
pointed out,
yeah.
It's not exactly as you just said. It's not the typical patient. It's actually
not or the way we see it today.
Right.
Yeah,
And frankly, I was just actually editing a chapter in my book, and I was writing that when I see an 8-year-old with type 2 diabetes, it's never because they eat any differently than any other 8-year-old, and it's never because they aren't exercising or trying to be healthy. It's
Right.
always something different. So that's
Yeah.
sort of, my story. I was naive 20 years ago, right? Like I didn't actually know what I was doing. And I thought, I just thought somebody should try because as
Yeah,
a
you have
surgeon,
the passion in your heart to try to help. And
yeah,
I
as surgeons, we make, there's that one surgeon joke, frequently wrong, but never in doubt. And it's sort of similar. Like I wanted to try, even if I had no idea what I was doing and whether I was totally wrong, it didn't matter because I was going to try when
Right.
basically most of the country wasn't even willing to try.
Exactly. I totally respect that. And I remember when I first was getting into the field too, I just thought, oh, this is just calories in, calories out. And I'm a spreadsheet person. So I had these like very intricate spreadsheets, and then I had the gas exchange system to measure metabolic rates, like way back in the 1990s,
Mm-hmm.
and was doing all of this crazy stuff with tracking everything and calculating. And then I was thinking, geez, at first it seems like it works because, as we know, you can force your body to lose weight in the short term, but then it didn't take long for me to totally abandon that kind of process after seeing what you see. And so then, that understanding of obesity in children or adults as I like that term, like American Heart Association came up with originally, or American College of Endocrinologists. It's the multi-metabolic and hormonal disease state. It just kind of encompasses a little bit about what you say, Dr. Nadler, about obesity is not like one thing. It's so many different things that funnel into the condition, and they're different for everyone.
Yeah, and I think like one of my messages when I'm out there on my soapbox is that the lessons from childhood obesity can really inform how we view adult obesity because there are still too many people in the adult world who are focused on food addiction or lifestyle medicine. Not to bag on the lifestyle medicine people, but like when you talk about lifestyle medicine, again, it's almost like, well, obesity is not a disease. We just need to fix your lifestyle. And if we fix your lifestyle, you'll be okay. So it really actually sort of irks me, although I do my best to hold back on LinkedIn and other platforms, when I see some of these online influencers or, even docs with huge followings on on LinkedIn or other social media platforms when they talk about, I saw a post the other day that said that, if we, with lifestyle medicine, we can reverse obesity or something, simplifying it, but something like that.
Right.
And the guy who posted it has I don't know, 40 some odd thousand followers on LinkedIn who are getting a message that's, actually abjectly false based on
Inaccurate.
the data that are out there. Like, we have lots of data to show that that's not true. But here's a guy with an MD after his name at a respectable institution talking about it. And I think it just, unfortunately, sets things back or holds things back.
Well, that's so interesting what you're saying, because that's been my experience too. I totally relate to what you're saying. So you can feel free to speak.
Well, so one of the reasons I think, and maybe, I don't know your origin story, Emily, or how you got into podcasting, but, I left the busiest pediatric bariatric surgery practice in the country that I'd created from scratch, doing twice as many surgeries for kids with obesity than anyone in the country each year. And I gave that up and I gave up trying to educate our medical colleagues because I was just so frustrated by it. And I decided, just like Skyrizi, like, who knew plaque psoriasis was such a huge problem until Skyrizi came along, and now everybody's talking about Skyrizi. So I decided that the direct to consumer marketing might actually, or in this case, education, might actually be a way to go because, again, I'm sure you've banged your head against the wall for a long time, and I feel like, I don't have any hair to cover that up if I do that. So I had to get out before I got too many dents.
But Dr. Nadler, let's set a baseline. I'd love to know, what do we really know about childhood obesity now? What do we know about the numbers, and are they increasing? And what's the connection between childhood obesity and adult onset obesity? So, set the baseline, if you would, just about this topic, and then we'll take the deep dive.
Sure. So there are about 15 million children in the U.S. currently who suffer from obesity. And the vast majority of those children will go on to adulthood with obesity unless they have treatment. And while, obviously, if you have 140 million adults with obesity, there are more people who've developed obesity later in their life than childhood. But I'm sort of I sort of believe that it's all interconnected, in that the genetic predispositions sort of express themselves differently. And the folks who have developed obesity in childhood are probably those who have sort of the highest level of genetic or epigenetic influence on their weight or their metabolism or their overall health. And then maybe it's just less so in someone who develops obesity at 30, and even less so in someone who develops obesity at, let's say, 50. So we know a lot more than we did 20 years ago when both Dr. Cooper and I started in this field. But there's still so much unknown about even like the basic causes of obesity, or even how some of these obesity medicines work. Like, we're just scratching the surface of the science, really, in my opinion.
Andrea, I'd love for you to jump in and tell Dr. Nadler briefly about your story. That would, I think, illuminate a lot of this stuff.
I would say, my background is I was chubby kid, got chubbier, always was on a diet. I'd say the doctors probably put me on a diet a real diet when I was probably 8. A restricted calorie diet. They told my mother, oh, she's too fat. And the funny thing is that the doctor who put me on a diet, he was very fat, but but he said I was too fat. And, my mother, it wasn't like that she was being mean or anything. She was always concerned about her weight too. So it was like, oh my God, we don't want her to be fat. So diet happened. And as we tried to, when I first started working with Dr. Cooper, it was like we tried to figure out how many diets I've ever been on, like serious restricted calories. We're talking like 800 calories a day type of diets. And it's at least 50, 35, 50. Um, and it probably started when I was 8. So, and I never ate more than the other kids. I probably ate less. And I have genetic predisposition to it. And we did some genetic testing because we thought I could get on some new drug that was being developed. So I did get fancy genetic testing. And I have a bunch of the genes that, said, oh, you're going to be, that's your destiny. Ooh. Um, so, but,
And your
you
mom
know,
had
my,
gestational.
right. My mother. Oh, and then we found out, like, seriously, I found out when I was like 50. My mother was like, oh, yeah, I had that gestational diabetes. Oh, yeah, I had that. I was like, oh, could you have told me? She's like,
Yeah,
oh, I didn't know it was a big deal. Um, so it was all predestined to happen. Um, but had there been like what was going on now when I was a kid, I would have totally, I think we could have prevented so much.
sure. So it's funny that you say that about your mom and gestational diabetes, and the intergenerational transmission of obesity, which we'll hopefully get into a little bit, is one of the topics that I talk about the most and studying and try to explain to people. But to take the edge off, often when kids come to see me, and I'll be interested in hearing what Dr. Cooper's approach to that is. But everybody often patients come to the office with shame and blame, both the parent and the kid. So as a sort of tongue-in-cheek joke, depending on how I read the room, and occasionally I have misread it, which is awkward, and we won't talk about that. But I often say, I don't care how you got here. Let's just move forward with tackling the issues in front of us. But if you need to blame someone, blame your parents and blame your mom. Depends who's in the room, like I say, because it's their fault. Like it's not your fault. You were born with the genes you got. Like
Yep.
you can't do anything about that. And the same thing with gestational diabetes, which we now know impacts childhood obesity risk and diabetes risk far more than we understood. And actually now even neurodivergence or autism spectrum disorder risk, which we didn't really know. Well, we certainly didn't know about the neurodiversity, but we didn't really know the impact of the in utero environment as much way back when as we do now.
So, Dr. Nadler, Andrea's parents' response to her weight was to restrict calories. And I'm guessing that you see that as a common thing when parents come in. I'd love for you to just speak to parents out there. And we've got parents listening from all over the world in over 100 countries. If their child has excess weight, when should they be concerned and what is the appropriate response?
Yeah, if I had the answer to that, I wouldn't be like printing money in my basement. So I am a big advocate for parents or prospective parents thinking about their health before they conceive. Not everybody knows when they're going to conceive, but especially if they're planning to try to have a kid, I would encourage the OBGYN folks out there or family docs or whomever to talk to their patients about, you can really optimize your kid's health by taking care of your own health before you get pregnant or while you're pregnant. So the time to get concerned is actually prenatally, and especially if you have obesity issues yourself, because that'll help with some of the risk. And then the appropriate response, that's really the $1 million question, because, if you have a high genetic pressure towards obesity, what can you do? I mean, I do think that this is where lifestyle changes can be helpful, not in a necessarily restrictive kind of way, but, if you know that your child is going to have a high risk of obesity, encouraging better eating habits for the whole family and, exercise for the whole family and fun things to do that make everybody move a little bit more. And Dr. Cooper knows, and probably many of your listeners know that weight and health aren't necessarily inextricably linked, but they're definitely linked. So if you can't, for some of those patients and their families, maybe they can't necessarily control the weight gain, but they can improve their metabolic health such that the weight gain doesn't necessarily impact them as much as it might. And then, when the time comes with seeking out an empathetic and compassionate docs, not the one that Andrea saw when she was a kid, then they can get some guidance as to what to do and when to do it. And it's really a personal choice. I mean, I think, we talk about meeting patients where they are, which is important. And not everybody's ready for their kid to go on a medication or have surgery or anything. So I think it's, I think that's where the art of medicine comes in, is really trying to work with families to understand, like, what are they ready for? What can they do that actually is going to make a difference? Don't set them up for failure. Don't say, listen, go, I want you to run a marathon by the end of the month, so start walking today. Like realistic goals, they're achievable. There's a lot, and it's hard. So I don't have all the answers. It's easier to pick out the wrong answers than it is to
that's true.
have the right answers.
I would also say take the obsession part of it out of it, because so many times when I was younger, they would put like this obsession part in it. Like, okay, you have to lose 75 pounds. And it's like, oh my God, like, how is that going to happen? So then in my head, I mean, for years, like 50 years, it was in there. Like, I have to be this weight. I have to be 120 pounds. I have to be 120 pounds.
Good point.
And it's like, that's been really hard to take out of my head forever, forever.
And that's why I try to make the point about, even though I'm an obesity treatment doctor, it's really about health, right? It's not about weight. And like, I support the fit at any size movement, as long as you truly are fit. And I often say that my only issue with those guys is that they sort of, the judgment that they don't want to get, they sort of judge on people who go get medication or surgery. So it's kind of like, let's all accept everybody's choice as an individual, whether it be to live at that size, to get medication, to get surgery, or to do all of it, or whatever. So there's just way too much sort of, in this field in general, there's just so much like us versus them, or we're right and you're wrong, or, I don't know why. It's just weirdly not collaborative in many ways.
I think it's really interesting, Dr. Nadler. You're using some of the same language that Dr. Cooper has used, the art of medicine, the importance of prenatal health. Dr. Cooper, when a kid comes into your office who's clearly obese, how soon can a kid get on medication that will make a difference?
Well, it depends on their age, for one thing, because medications are approved only at certain ages right now, age 12 and up. So the first one was Saxenda, which is liraglutide, and that was about 15 years ago now. Was it 2010? Yeah.
Mm-hmm.
And so, or no, sorry, 2020. Was it 2010?
No, it's 2010.
It was 2020.
But it wasn't, I don't think that's when it was approved for weight management.
No, so 2020 was approved for weight for kids. It was approved for kids 2020, I believe. Yeah. And then shortly after that, the Wegovy was approved for kids age 12 and up. So, first it's looking at their age, obviously, and whether they meet that criteria. But I'm a big advocate of like finding out that part, like the multi-metabolic and hormonal disease state. What is really the mechanism? What can we find out and learn about the mechanisms that are driving it? And not so much from the lifestyle part is definitely an important component, but more from the objective evidence that we can find on maybe laboratory testing and, if possible, genetic testing in some kids that have more severe presentation. And so once you see that information, it can help guide treatment, basically. And so it may be that, especially with kids that are young, you wouldn't necessarily start them right away on a GLP-1. You would try to optimize the lifestyle, like Dr. Nadler was saying, for everyone. But the lifestyle that we focus a lot on, especially with kids, because we see huge deficits here, is sleep. How sleep is so important for metabolic function and for growth and development and everything, basically. But so many kids are just shortchanging their sleep so much. And so, focusing a lot on just that quality and duration of sleep, the quality of their nutrition, just like we would with every kid, no matter what size they are, basically. It's just health and it's metabolic health for all of us that we should focus on. Stress, trying to figure out how to keep the stress levels from mounting too much, and physical activity, fueling your day adequately, not going long time without eating and then ending up eating kind of stuff that's not real food, that we really need the nutrients. So again, kind of in my practice, whether it's a child with obesity or not obesity, or an adult with or without obesity, it's like everyone really gets the same metabolic health lifestyle education, because as Dr. Nadler said, it's not like that's going to change your weight, doing the healthy lifestyle, but it's important components of our health, no matter who we are or what size we are. So I focus a lot on that. And as Dr. Nadler said, like really look at that family history, where this is coming from. And I do a similar thing that you do. I kind of blame the parents a lot, just in a funny way, because the kids really are tense and they feel like, oh, it's another doctor. A lot of them have been to doctors who really have blamed and shamed them and scolded them. And the parents are just paralyzed because they feel like, as you said, they feel somehow they did something wrong, and they're concerned. But the kids are really pretty smart, I mean, they know there's more to this than being told to eat this way and do this exercise. They know there's something different about their system because they see other kids that are, don't necessarily have this healthy lifestyle, and they don't seem to have a problem. So they're kind of like, this isn't making any sense. And part of, if it's pushed too much on them, that whole kind of diet culture and all of that, it could actually trigger them to go like totally in a weird direction where they wouldn't have before, where now they're kind of rebelling in a way where now they don't care what they eat. They don't care how they take care of themselves. And it's more of a statement. And so it could actually trigger behaviors that wouldn't normally be there, that could impact their health. And so once they're in that, I know what you mean by it's very, it's kind of like the expectations are there of what's this doctor going to tell me to do. So it is kind of fun to just, talk about the genetics and how, hey, this is not your fault. If you want to blame someone, and in our practice, we have a lot of families, so we already know the parents have metabolic issues. And so we're like, oh, well, just like you got that part from your mom, that got that part from your dad.
Yeah. So one thing, Mark, I want to just elaborate on that Dr. Cooper briefly touched on, which is the FDA-approved medications. So what many weight management pediatricians are forced to do is use some of the medications that are approved in adults off-label. So in kids, meaning in kids that they don't have an FDA approval for, or even, one of the ADHD drugs can be used for binge eating, and it does have some appetite suppression and some value in kids as well. And so depending on the practice, you asked what age a kid can get offered medication. There are practices out there, including the one that we had in DC before I left, that would offer medication to children far younger than the FDA approval ages. And frankly, the surgery that the sleep gastrectomy, which I would do for kids, I've done in kids as young as 4. So there is no, like there to me, and I'm sure Dr. Cooper feels the same way. If you have a disease, it doesn't really matter what age you have. I mean, what age you are when you have that disease. We want to work with you to get you healthier, and we'll explore all the available options, even if some of them are somewhat, let's say, out of the box compared to what, or at least that's I was an out of the box kind of guy, as you might already have gotten a sense of. So the I want parents to, at least hear the message that there are options. Don't think just because your kid's, let's say, 5, that there are no options out there. There
Sure.
are options.
I think one of the things is too, again, when you get down to what's the real picture, these individual cases. And I've had kids as young as 4, also that had to really, well, we've had kids as young as 2 that we're monitoring, but as young as 4 where we've had to start some form of pharmacology. Um, and you do what you need to do. It's true, but it is really good to kind of focus on what is there a way to stay within those FDA guidelines where there is a way you want to, but there are definitely going to be cases where that doesn't make sense to sit and wait until a child ends up at 12 years old. One of the problems in pediatrics is that studies have shown that whether it's male or female, there's so much going on with kids. So you've got the females, the main growth spurt is like 9 to 14, age 9 to 14. And for males, it's like 10, 11 to 17 or so. So it's during those growth phases, that's when the metabolic system, all this metabolic dysfunction can really flare up, because of growth and development. And so what you could end up seeing is you can see these kids put this abnormal amount of body weight on, but not actually attain that vertical height achievement that they're supposed to be, that corresponds to that weight because of metabolic disruption. And so you need to do something because you want them to develop appropriately and grow the way that they're supposed to. So monitoring kind of that height and their growth hormones, and males testosterone development, females, all of those hormones are so important to look at. But it helps you make a choice with kids, and having a really good, conversation with parents about it. If there is, you kind of, I think for parents, when my practice, what I do is I mention some of these things that might be off label because of their age, but then I say, well, let's try this first, let's see if this works. And then let's see if that works. And then you kind of prepare for the conversation that, well, we got this far, but you see, because we're entering further into the growth spurt, we're getting more and more amplification of the metabolic dysfunction. So having something to counteract that can be, extremely helpful. So it is the kind of thing that you can't tell them on one hand, well, it's not your lifestyle, and then not offer anything to them. We improve your lifestyle for your health, but that's not going to solve this obesity problem. And then not offer them anything, that will help. But one thing that was really great, back about 15 years ago. So we're talking about 5 years ago, the Saxenda was approved in the 12 and up. That was the first one. But 15 years ago, a group was looking at University of Minnesota. They were looking at exenatide, short-acting exenatide in girls age 9 to 14. And I really hand it to the researchers there. I think it was Aaron Kelly.
Yeah,
But
I think it was
yeah,
Claudia Fox and Aaron Kelly, probably.
yes, yeah, and it was amazing because they showed that these girls, I mean, they responded really well. And this is exenatide, which is not very effective. And they did twice daily dosing. It's short acting, the very first GLP-1 that came out in 2005. And so now 15 years ago, they did this pilot project, and they did another one that was even bigger. And they showed effectiveness for the pediatric group with good safety and good tolerance, and even a little better tolerance than we see in adults, really. And the fact that it was a shot twice a day didn't really seem to bother those kids. So that was really, I think, groundbreaking and reassuring to those of us that were in the field, in the pediatric obesity field, to see. I mean, it was so good, wasn't it, Evan, to see that?
Yeah, no, I was just thinking about their comment about kids tolerating it better. And,
Yeah.
I in my crystal ball, I'm predicting that in, maybe before I hang up my scalpel and my prescription pen, or e-prescription these days, that people will understand the earlier you treat the disease, the better the outcomes will be. And like with surgery, just like the meds, the kids do better. They do better than adults in general. And it's sort of like this contrary thinking to what everybody else has always traditionally conventional wisdom. We have to try everything in adults first before we can try it in kids because we have to protect the kids, this and that. But it's that paternalistic sort of dogma that has really held the childhood obesity field back because, again, we have everything has to get approved in adults first before it even gets to kids. And so it's like they're it's another reason they're sort of behind the eight ball compared to the adult world. So all of it is, it's an uphill battle that we're fighting.
Right. I totally agree that the kids, the earlier the better that you start working on this. And it's so rewarding because it's so true that, we've got some kids. I saw one yesterday who's 14 now, and I started with her. She was 4, and she was one of the ones we had to be very aggressive with. Um, and she's just doing so well compared to where she would have been. And at 14, it's the peak of metabolic dysfunction. And so, because of starting early and having a handle on this, going into that like peak puberty, and I've seen kids too, all the way through till they're 17, 18, 19, starting out really early with pharmacology. Or I want to hear more about the surgery in a bit, but with this pharmacologic approach, having really good outcomes for these kids as they go into young adulthood and even start their own families. And as you talk about that.
I need you to speak to my literary agent because she asked me, why do I need to explain the normal growth and development and adiposity rebound and all those things? She's like, why do we need to understand that in this chapter you're writing? And I'm like,
it's huge.
So that's part of what I'm editing now too, because you need to understand that abnormal weight gain during these critical periods of growth and development are, while abnormal weight gain at any point in childhood is not great for you, it's even worse for you if it's at these critical inflection points during normal growth and development. So I'm going to send her your
make that connection. That's great.
Clip and send it to her and say, this is why.
There you go.
Well, I'd love to dig deeper into the surgery, Dr. Nadler, in just a second. But first, I'd love to know, I think a lot of us have seen like examples of quote unquote baby fat, like, oh, that kid's chubby and he'll grow out of it or something. And it seems to be very common. What's the difference between obesity and just these sort of normal accumulations of fat that tend to go away as we get older?
Well, I would argue that there aren't a whole lot of people who grow out of their baby fat unless it's their baby fat before they're walking. Toddler, babies right before they start walking accumulate a lot of fat. And then once they become toddlers, they tend to lose it. And then as Dr. Cooper was just explaining, they tend to gain it back as they sort of get towards puberty because that's normal. But the people who have excessive weight gain don't generally lose it. So that's why it's important, as Dr. Cooper was saying, to actually be monitoring kids during these periods because the average parent doesn't know how much is too much or when it's starting to affect their kid. But sort of the simplest way, and there's, you've probably already done an episode on this, and you could spend a whole nother episode on it, is defining obesity, which I alluded to sort of earlier about the multiple pathways to get there. But at least in my mind, I try to simplify it into this. If a kid or an adult's health, mental or physical, is being negatively impacted by their weight, then that to me is sort of a loose definition of obesity, or at least of excessive weight that deserves some attention. And the debate about whether obesity as a term should be changed or replaced, again, a topic for another day. But I think for your listeners, if you're concerned, go see your pediatrician, and hopefully your pediatrician will be able to help you determine whether you actually then need to go see a specialist or not, if you have one available. Because unfortunately, pediatric weight management programs are scarce, and that's a whole other topic for another.
And you don't want to send them to anyone that scolds.
Right, you don't want to. That's right. We're going to get the name of Andrea's doctor and circulate it.
I think he's dead. I think he's dead.
But Mark, another point is that I do think there is a little bit like of potential caution, because I think there's so much paranoia with parents about their child's weight, and that we even get people who think they've got a problem when they don't, because with our society and everything is so skewed. And so it's normal for children in that growth phase that put some weight on and then they grow. And so those steps of growth, there's often, the vertical height is often preceded by a little bit of extra weight that than they normally have on their body. And then they grow taller and it's gone. And then it happens again in these various, like a sequential thing. And so some parents panic when they see that. And so, especially if you have kids that are going to be really tall, that are going to grow like 2 inches at a time. Sometimes it looks a little different in those kids. And also their appetite's going to be really high because of the growth phase. So sometimes there is a misunderstanding or like some confusion around that. And so, but again, as Dr. Nadler said, you could just a physician can check and see where they really are and whether there is anything unusual going on. Check maybe some lab work and see if there's anything unusual going on there, and decide if it is or isn't an issue. But I think that more and more we do have to be sensitive to the like disordered eating, epidemic that's out there, that people are afraid of having any body fat, and thinking that that's abnormal, and they're afraid of they're basically afraid of food and everything. I mean, this is the subset of patients that we encounter a lot, that there's also kind of some concern when there isn't really an issue. But then a lot of those people too, what's funny is, as we said, like you can be healthy and have high body weight and be healthy. You can have normal body weight and be unhealthy. And there are people who are at a normal body weight, and they too have metabolic dysfunction that requires these same pharmacology. Like you, Mark, we've talked about your case. You have metabolic syndrome at a relatively normal weight, and that is a subset of, especially of people, males and females, but especially in males, it's been studied more. And you would need the same like constellation of medication probably as somebody who has obesity. So that's where we have to get our head out of it. So if parents concern, we want to look and see, is there a weight problem? Well, maybe not, but is there a metabolic problem? Maybe not. Just check it all.
Yeah. So let's dig into surgery. Regular listeners, you guys know Andrea's story that the drugs, the pharmacology worked up to a point, but then it wasn't quite enough. And bariatric surgery was something, Andrea, that you had to do, and you very successfully went through that, and it worked. Dr. Nadler, at what point do you decide that surgery is the logical option for a kid who's overweight?
So I think there are lots of points to touch on there, including just word choice. You said something that Andrea had to do, something Andrea chose to do. The patient choice, again, is sort of really important to me. And I think the collaboration between, we talked earlier briefly about cancer as a diagnosis, maybe in the cold open, so maybe it's not going to be part of this. But I like the cancer analogy because in cancer, we don't talk about surgical resection only, and we don't talk about chemotherapy only. We have protocols to try to figure out what is the best combination of the two that optimizes the patient's health in the long term. And so that's the way I think about obesity treatment. So in our clinic, in our intake for our pediatric weight management clinic, we talk about all the options from lifestyle, IHBLTs, pharmacology, surgery, and then sort of work with the families to figure out what they want or think is best for them. So I actually do not personally advocate for surgery being a last resort. I think that's sort of what you were describing in Andrea's situation. And I would say that that's not actually the most, I think, most useful way to use the surgical option. I think again, and some of it comes down to what Dr. Cooper was talking about is like, what's the driving factor behind your weight gain? But, if you have a high genetic, if you get one of the free genetic tests that are out there and you have a lot of mutations that may contribute, or you have one of the known mutations that we know does contribute, that can change the order, or at least I don't want to say pressure because that's not quite the right word, but it may make it so that I'm more inclined to push you a little bit towards surgery if I know that the likely pharmacology isn't going to work. But I think the research that really needs to get done is, medication response. Does it predict surgical response, or lack of a medication response? Does that predict surgical response? Is there a best algorithm for meds before surgery or meds after surgery, or is it meds, surgery, meds? Like, like what is actually what's best for the patients? And no one knows, and maybe we'll never know. But because everybody sort of has their own way of doing it, it's going to be a difficult question to answer. But my personal opinion is that if patients are inclined for one option over another, you should reinforce that option, in my opinion, and then just let them know that there are other options if the option they choose doesn't necessarily work out. Like I tell all my patients who get surgery, there's a chance you're going to go back on medication if you've been on it, or if you've never been on it, there's a chance you're going to be on medication afterwards. And obesity is a chronic disease, and just like any other chronic disease, you might need a lifetime of treatment. So the whole idea that surgery is one and done, I think that was an idea that some people held 15, 20 years ago when we first started doing this. But it's been proven to be not correct for a lot of people. The people it turns out to be more correct for is actually children. The long-term data in children are actually better than the long-term data in adults, in terms of not just, even in patients who regain weight, their metabolic improvements can persist up to 15 years after surgery, which is a really interesting, and it's actually that's not published yet, but those data were shown to me at a meeting. And the 10-year data have been published from the Teen Labs Consortium, which is the group that really sort of pushed the envelope for bariatric surgery in kids. But, their 10-year outcomes are great. And their 10-year outcomes are better for diabetes control than adult 10-year outcomes. So again, I think, and it just makes logical sense to me anyway, like the shorter duration you've had of a disease, the more likely you are to be able to treat it, effectively. So, I think again, maybe someday the whole world will understand that the earlier the better, and the lower the BMI the better, and all those things in terms of treatment options. But we're not quite there yet.
Just so you know, I always knew going in that mine was going to be a combo platter of medication, surgery, medication all together.
Well, Andrea was a really good responder to pharmacology for the first, you said, what did you say, Andrea?
How long was I?
It was like 80 pounds or so.
Yeah.
But, yeah. And this was back a long time ago. And
I started 15 years ago.
You started.
Yeah.
12 or so.
12.
But in any case, Andrea was a great pharmacology responder. And you had a health problem happened, and it caused a big setback metabolically.
Because I had a health problem and had to take steroids, and then there was
And then following that, you went ahead and did the VSG, which was really nice procedure, and then following that, you went back on your meds,
and then But we knew that was going to happen.
Well. Right. And so I think
that was going to happen. Yeah. So then after that, like another 90 pounds have come off.
Yeah.
Or 90 maybe.
I think a really important point with that again, we unfortunately haven't really completely grasped as a medical community is, you knew that up front. Hopefully your doc knew that up front. And
Dr. Cooper.
But most patients don't hear that. Most patients don't hear that your surgery is not going to completely fix you
No,
20% of the time.
right.
And a lot of surgeons, I have to say, a lot of surgeons are out there. You see them on LinkedIn even stating that surgery is the be all end all. I have about 250 patients that came to my practice after having had
Sure.
a lot of weight gain after they've had surgery. And I have to tell them, well, this is normal. And I do the calculations. I say, oh, well, you're actually doing better than what was. And they're like, what? You know?
So,
But-
and then the other point on the same thing, and I totally agree. And I have to admit that 20 years ago when I first started doing this, I had some of that same
yeah, because you
sort of hubris until you see your patients and you're like, oh, well, actually,
yeah, me
it's not
too.
quite as great, is it? Especially if you're working on kids who have a higher genetic drive towards obesity. But the other thing that I wanted to make sure people hear is that I can't stand the word failure. You know, like your procedure didn't fail.
No.
You didn't fail. Like it's just the disease.
Yeah.
And going into that operation, again, you knew it yourself because you're, you know, in tune with your own health and you're savvy about this. But lots of people don't. And then when they regain weight or they don't lose as much weight as they thought they might after surgery, either they view themselves as a failure, they view their surgeon as a failure. You know, unfortunately, the first thing that happens when they come back to the clinic is, oh, what are you eating? How are you cheating?
Yeah,
like, what are you doing that's not appropriate?
Right.
Which is totally wrong. It's just the biology. And, you know, there's a lot of data now. So I published data on liraglutide after sleeve gastrectomy in a cohort of teens. And now there's another publication that's out there on sort of when to restart medications after surgery in kids. And, you know, I think the needle is moving definitely towards more aggressive pharmacotherapy in combination with surgery, but it still needs to move more because there's still a lot of surgeons out there who don't quite necessarily agree with that or know that that's going to be a helpful option.
I think it's so great to give that awareness to the patient when they come in to explain, oh, your response is predictable. You know, this is a predictable response. And I think that a lot of them are like, wow, I wish I had known that.
And then the normal weight gain at 1 year post-surgery, you know, and like you follow that normal weight gain and just make sure it just doesn't keep going in that direction. But, you know, most patients, their curve will go up a little bit and then plateau again. And if that's their curve, that's great. But you want to catch the ones where the curve is continuing to go up sooner rather than later so that you can intervene before it goes up too much. So there's a lot of, I hope there's a lot of better understanding about both surgery and medications and how they work. Although I joke that we don't really know how GLP-1 medications work because it's different after surgery. Your GLP-1 levels and surges are different than they are when you get a medication through an injection or a pill. So we still don't quite know how all these things work.
And even I think in the surgical research, I guess it's getting better now. There's longer term hormonal studies, but for so long, the hormonal, changes were only observed in this very short window of time. And things, I think that it shows that further you get out, you kind of lose some of that benefit. So,
yeah. And the other topic that I'm sure you've done an episode on, but is important and people don't really understand is the whole idea of metabolic adaptation. Like people don't understand.
We're all about it.
That losing body weight, your body defends its weight, or there are all those sort of catchphrases that we've all heard over the years. But they're accurate. Like and again, I think we certainly don't I like to make fun of surgeons. I like to make fun of myself. I like to make fun of everybody, including myself and surgeons. But when I'm making fun of the surgeons, I talk about the fact that, like 1991, the NIH Consensus Conference decided that, bariatric surgery was indicated in patients over a certain BMI because it helped with decrease the risk of early death, whatever. That's 91. So that's 25. That's 34 years ago. And we still have no idea how the surgeries work. We don't have any idea how they work. And it hasn't changed, right? And I think it's fascinating personally that the BMI change after surgery tends to be about 13 to 15 BMI units, no matter what, no matter who you are. Like, yes, there's super responders and non-responders, but the average, whether you get, bypasses a little bit more than a sleeve, but it's still that number. And that number really hasn't moved in 20, 30 years. It's fascinating. Like, I don't know how that works. Like, I mean, obviously there's gut-brain axis, there's hypothalamus, there are all these things that are important. But if anyone out there can tell me exactly how bariatric surgery works,
Yeah.
I dare them to try.
Well, and we've talked about it here on the podcast when we talk about surgery, how fascinating we call it, metabolic surgery, and how it, within just days of the surgery, there are these hormonal changes. And so that's why we try to explain to patients that we are referring for surgery, that it's not because we're trying to make you eat less. We're trying to get this metabolic benefit. And because they'll say, well, I already have done all these diets. I know how to cut my food down. It's like, no, that's not what it's about. I mean, within days of the surgery, that has nothing to do with what you're eating. It's just these hormonal changes that are occurring.
And you're aware of the data that people are off their insulin before they leave the hospital, which
Yes.
doesn't make any sense whatsoever. And it led to what I don't know if anybody's familiar with the term snipe hunt, but that was a joke in growing up. And I call the Barrett the room gastric bypass led to the great snipe hunt of trying to figure out what was the one metabolic mediator, what was the one compound that was in charge of this amazingly different transformation over the first 3 days. People spent decades. People are still looking for it, and no one's found it because I don't think it exists. I think it's
and that's a great
it's probably partially vagus nerve to the brain, or combination of the incretin hormones and the vagus nerve, but
multi-metabolic and hormonal.
Right, exactly. I actually, maybe it's too much of a mouthful for me to say because I'm just a simple surgeon and I can't use all those words at the same time.
You have to make an abbreviation.
What is it?
Multi-metabolic and hormonal.
MMHS.
HDS.
There we go.
Oh my God.
I don't know about the D. I might leave the D out. MMHS. These two.
Metabolic hormonal state.
But it sort of leads to another discussion, again, for probably another day, although probably the four of us could talk about this topic for hours. But I personally am skeptical, and maybe it's because I'm a surgeon, but I'm a little skeptical that there'll ever be a biagonist or a triagonist that actually can do as well as surgery, because I think there are just too many mechanisms in surgery all at the same time that no one will probably be able to recreate that with a molecule. I just don't think. I mean, obviously, retatrutide is the next big thing, the triagonist, and maybe it'll get closer to surgery. Maybe. I don't know.
It goes back to what you were saying before. It's really so individual, and I think that too, when you were talking about why, one person responds a certain way and another way, or when you should refer to surgery, it's all so individual. So I just think you'll have these, ultra responders in both camps, and then you'll have the resistant people in both camps, and they may not be the same people, but
I actually my LinkedIn post today, or my LinkedIn newsletter today, was about the bell curve. And how people don't it's like the most boring topic, right? The bell curve and statistics. But the point is that when you get a report that the average weight loss for tirzepatide is 20%, that means half the people will not lose 20% and half will. And actually, there'll be super responders and non-responders, 5% on each side. Yeah. And then actually only the first standard deviation only makes up 68% of people. So that means a third of people basically are either going to lose a whole lot less than the average, or gain a whole lot less, or lose a whole lot more than the average. Yeah. So it's just, as you said, it's all individual. And then when the food is medicine people or the MAHA people talk about, the food changing people's health with obesity or in general and helping them lose weight, I always say to them, there is no way that, the bell curve always wins. So there's no way that that's going to work for everybody. It's just not possible. It is just scientifically impossible that what you are saying can be true, because that was actually the start of my LinkedIn post today, was that
I want to
the
see.
bell curve has never lost. No one has ever beaten the bell curve. That's always the case. It's not entirely true.
And that's also why
but
it's irresponsible for people to market, even physicians marketing, or these quote weight clinics and all of that to market, come here and you'll lose X% of your body weight before they even know the person or know anything about them. So our viewers should really be aware of that.
Well, we've got to wrap up in just a sec, Dr. Nadler. I wanted to ask a really quick question, though. Are the bariatric surgeries options, are they the same in adults as kids, or do you avoid some when you're operating on kids?
So back in the 2004, when Teen Labs Consortium started, which I was not part of, they were comparing, the research study funded by the NIH was to compare gastric bypass in kids to gastric bypass in adults. And one of the big reasons I wasn't part of that study is that I thought gastric bypass in kids was not a good idea and not likely to be the long-term solution for that age group. So that's why I actually started doing lap bands, which that didn't turn out to be the greatest intervention either. But about 5 years into Teen Labs and about 5 years into my lap band experience, both the Teen Lab group and myself really started performing sleeve gastrectomy more commonly in kids. Mm-hmm. And now today, the sleeve gastrectomy probably makes up about somewhere between 95 and 99% of the operations that most children will get, depending on how you define children. And I think, especially with all these great medications that are out there, if I were advising anyone, kid or adult, frankly, depends on the adult's comorbidity profile and some other things. But I do sort of like the idea of a stepwise approach in that, if you do a sleeve and you need some pharmacological help, I think that's probably still better in the long term than a 16-year-old getting a bypass and having to live with that malabsorption their entire life.
I want to hug you right now. I want to hug you.
I thought you said you want to hit me.
This is the first person that's a surgeon who has actually said this, because surgeons get upset with me when I'm trying to refer patients, and I try to encourage them to do this, like Andrea had the sleeve gastrectomy. And I just think that procedure works so well for our patients. As you said, so if they put a little more pharmacology on, yes, I guess, I mentioned in one of our episodes that the surgeons think I'm nuts because I'm so paranoid about the malabsorptive procedures. But I think it's because I've had patients come in who are in terrible shape. I have seen them. And so if there's any way to avoid that, right. But as you said, there may be extreme cases where there may be a need for something more invasive, but I just want to hug you because you're the very first surgeon who's
virtual hug.
I have there's another surgeon locally who kind of is.
So I think,
but
because I was dealing with kids, it was fairly easy for me to think about growth and development and be focused on the malabsorption. So again, the Teen Labs data, once they started doing sleeves, shows that the sleeves actually do almost as well as bypass long-term in kids. And I think, the data also show that if you convert a sleeve to a bypass, you actually don't get that much extra weight loss. Mm-hmm. So that suggests that the bypass isn't really that much better. No. And it's more probably biology that was driving the quote unquote, suboptimal response or whatever you want to call it. But I think, again, when I explain it to my patients, I just sort of talk to them about the stepwise progression and that they can always get converted to a bypass later or BPD or whatever if they need it. But if it were me and my kid, I would want them to try the least sort of complicated and the least complication risk procedure first, because if it works, you're done.
And you get paid less for those.
Do I? I don't get paid anything for any
Well, I
surgery.
mean, if you're a surgeon, maybe you
Well, I
don't
think
get
there was
paid.
between the academic guys and the guys who work at,
Yeah.
who work in private practice. Like,
Yeah.
I was a salaried.
Yeah.
Maybe that's why I was able to be so
Maybe,
honest and just
yeah, maybe
feel
that's why you,
I
yeah,
get,
because
I
the
get paid, I
procedure
get
is
paid
a little
peanuts no matter whether I operate a lot or operate a little. So
Yeah.
Yeah. Well, this has been really enlightening, Dr. Nadler. Really appreciate your time. I'd love just a really brief final comment from the gang. Andrea, what's your takeaway?
Look, I think that the the deal with surgery and kids, if I had been if it had been a thing when I was a kid, I think I could have avoided so much anxiety, so much agony in my adult life. I mean, it would have stopped so much cycling of, gaining 100 pounds, losing 100 pounds, gaining 75. Like it would have just, and mentally, like the room it took up in my brain, I think I would have been much better off. I would have had a lot more time for shopping or something. I don't know. I mean, it would have, it would have like,
Yeah.
saved me a lot of time.
Yeah. If you had a Dr. Nadler or Dr.
Yes,
Cooper
like
back then, I
I
think
mean, there
things,
was no such thing as pediatric obesity specialists.
Yeah.
I wish that there were more of you,
Mhm.
yeah.
to help a lot more kids now.
That's great, Andrea. Dr. Cooper, your takeaway.
Well, I'm just so glad to kind of talk to Dr. Nadler about, about your experience, and there's some synergy there, and there's a lot of commonalities in our experiences, and it's great to have, a friend in the field, and I'm glad to hear more about the surgery too, and the pediatric surgery options, because, I don't encounter kids too often that aren't responding well to pharmacology, or who have like serious health issues where we have to consider that. But definitely, I'm sure I'll encounter some cases where I'll be more open-minded to that.
Yeah. Yeah. I guess my takeaway, Dr. Nadler, is I just really appreciate your honesty. I mean, it's not often that doctors will say, I don't know. We don't know. But it's just super refreshing, your approach to what obesity actually is. It's a disease state. And I just love that you're a student of trying to figure this thing out. Super great to have you on the show. What's the message that you just want the rest of the world to know? You're in the process of writing a book. We'd love to have you back on the show when the book comes out. But as we wrap things up, Dr. Nadler, what's the message you want the world to know?
Yeah. So, again, thank you guys for having me. Super fun. Happy to come back anytime. I could talk about this all day, every day. I'm from New Jersey, so that's why you get the radical transparency, according to our HHS secretary. But I'm actually giving it to you. Andrew mentioned no filter. I also have no filter, which is sometimes a problem. But the tagline, the message, and it really comes down to obesity is a disease and not a lifestyle choice, and there's something you can do about it. And that, the added message is at any age, in anybody, and we do need more pediatric weight management programs in this country. By far, it's not even close to enough to deal with all the kids out there. So if anyone out there listening wants to start a program, has any interest in any of this stuff, send me an email. Dr. Cooper and I can tag team and help you set some stuff up. Because really, the mission is just to get care, affordable, compassionate, appropriate care to as many kids and adults as possible. That's the goal.
That's awesome.
Absolutely.
That's
Well
great.
said. Dr. Evan Nadler, it's been a pleasure to have you on the show. Thank you so much.
Yeah, my pleasure.
All right, this has been another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.